This is our diagnostic criteria for acute appendicitis. So non-compressible, greater than 6 millimeters. If you use 6 millimeters, you might have a few false positives. If you use 7, you might miss a couple. So somewhere between 6 and 7 millimeters is probably the money shot. But there's also other things that we can find that can diagnose acute appendicitis, like the presence of appendicolith can be suggestive, or surrounding edema can be highly suggestive, or a ring of fire. We'll talk about all those things in a bit. Here's a couple examples of acute appendicitis. So here in the top left, you've got a large fluid-filled blind-ended pouch and long axis, measures around 1.5 centimeters with an appendicolith in the very tip of it. Then that same structure in short axis now measured here from outer wall to outer wall, 1.5 centimeters. Definitely acute appendicitis. Down here in the bottom right, same sort of structure. This one was full of sort of this brown pus material that made it look like it had some material in the lumen. That one was acute appendicitis. And then here, the one in the bottom left shows us the ring of fire. So this is when we put power Doppler or color Doppler on the appendix. You actually see an increase in flow in the inflamed appendiceal wall. A couple of other nice tips when you're trying to make that diagnosis. Say maybe the appendix is 6.5 millimeters, and you're thinking to yourself, well, you know, I don't want to overcall it just because it's a little over 6, but it's not like a slam dunk acute appendicitis. Other things can help you, push you to make the diagnosis, like the inflamed fat around the appendix here. So we often see this sort of fat straining around the appendix on ultrasound, where you actually get sort of edema of the fat around the appendix.
But you can definitely have other things causing inflamed fat and pain down there. I just recently had a guy right lower quadrant pain, really interesting case, tons of inflamed fat, but he had dilated bowel everywhere, right and left side, some thickened bowel wall, and he ended up being a new Crohn's diagnosis. So inflamed fat by itself isn't good enough, but combined it can be pretty helpful.
Other things you can look for are whether the appendix actually compresses or not. So acute appendicitis should be dilated and circular, should not be ovular, because it's full of pus, so it's stretching the walls, right? As opposed to an appendix that's rather normal, it's easily compressible, or sometimes it's not circular because it's not distending the walls, it's not acutely infected. Then, of course, we can look for the anechoic presence of fluid inside the actual lumen. So you can look to see if the actual hyperechoic walls of the lumen of the appendix within the actual appendix itself, if they start to become anechoic, that's more suggestive of acute appendicitis than if you actually have those hyperechoic rims inside of the actual appendix itself. This is a patient who had bad right lower quadrant abdominal pain for about 3 days, and then a day before he came in had sort of this brief period where it got better, and then it slowly progressed and got worse again. So this was an interesting patient who actually ended up having a large abscess right next to his appendix, and you can see it in this image here. You can actually see the abscess sort of walled off, and then you can see it connecting over here to where the appendix ruptured. So this guy, instead of going to the operating room, actually ended up a perc drain placed in his abscess.